what I'm going to be talking with you about today is the concept of remission. What I plan to kind of talk about is to delve into this important concept as far as what do we mean by remission, and examine sort of the interrelated terms that we often hear of damage and relapse. Briefly touch on the getting there and staying there part, which is really what a lot of other people are going to be delving into during the course of this wonderful symposium. And how we'll be doing it is to use questions and examples to illustrate some of the meaning of these concepts. So in order to really be able to discuss remission and vasculitis, we first need to understand, well, what is vasculitis? This is a term that we talk about, that this really is the focus of this symposium, and it's important to have a firm foundation as far as understanding how vasculitis affects our bodies. Vasculitis really refers to inflammation of the blood vessel. And if we think of our blood vessels as tubes or pipes that allow blood to be able to reach our organs and provide them with oxygen and nutrients, we can think about it in this drawing here as far as this light pink purple circle or pink circle in which blood cells are then being communicated to our organs. So when vasculitis occurs, there is inflammation in the blood vessel wall, which here is demonstrated by these purple circles. And when vasculitis occurs, it can have consequences to the blood vessel. One of these is the blood vessel may become thicker, and when this occurs, the blood vessel becomes more narrow or blocked. And we can see here, this really doesn't leave a lot of room for the blood to go through to be able to reach our organs. Now, another consequence of vasculitis is that the blood vessel could actually become thinner. And so this may result in the blood vessel becoming wider. So this may result in an aneurysm. Or particularly for some of our smaller blood vessels, another consequence of the blood vessel becoming thicker is the fact that there could be a potential for a break in the blood vessel wall with escape of blood into those surrounding tissues. And this is why we see some of the consequences that occur when vasculitis affects different organs. So now that we've seen this as far as in a drawing, we can actually see what happens as far as in our actual bodies and tissues. And so this would be a biopsy of a blood vessel that a doctor might see when they look at it under the microscope. And this here is a demonstration of a healthy artery. So we can again see sort of that pink tube, which is the blood vessel with the blood cells in the middle. And this is what it looks like when vasculitis is occurring. And once again, we can see these inflammation cells both within the blood vessel and around the blood vessel. And we use special stains to look at this, which actually turns these the color purple. Now, in many vasculitic diseases, inflammation can occur in non-blood vessel tissues, and this is a biopsy taken of the lung in a person with granulomatosis with polyangiitis. And once again, we can see inflammation that's present as far as with this purple staining. So remission in vasculitic diseases is a medical term that's used when there's no evidence of vasculitis or disease-related inflammation that's causing injury to an organ or tissue. So this is still a lot of words. So let's look at some examples in 3 different organ systems as far as examples of what we mean by remission. So let's look first at the skin. And on the left side, we can see someone's leg that has a rash on it. And this is a rash that's related to active vasculitis. So when remission is achieved in that skin, the leg looks clear and we have clear skin. What about remission for the kidney? And one of the main ways that we assess kidney remission is by looking at the urine under the microscope. And we look for the presence of blood in the urine and also these structures which are called casts, and specifically red blood cell casts. And we can see an example of this on the left-hand side of the slide as far as in someone that has active kidney vasculitis. So remission in this instance would be when we look at the urine, we no longer see these cast structures, and this would be an example of remission in the kidney. What about the lung? The lung is something we assess not only by the person's symptoms, but also by imaging tests such as an x-ray or, as seen here, a CAT scan. And again, on the left-hand side, in between as far as these dark fields, which are natural, healthy, air-filled lung, we can see sort of this white haziness, which in this instance represents active vasculitis and is referred to as an infiltrate. And then on the right-hand side, this would be an example of remission in the lung, which is where this infiltrate has cleared. So what are some common questions that arise about remission? And one of those is, well, how long does it take for this to occur? And this will vary for each type of vasculitis and also for each person, but it's usually on average about between 1 and 6 months. So some examples include studies in granulomatosis with polyangiitis have found the average time to remission is about 3 months. For giant cell arteritis, it may be 1 to 3 months. Is remission the same as what we mean by cure? And the answer is no. When we use the term cure, we're really referring to an illness will not return. So either it goes away on its own, or we do something with the treatment that makes it go away. But again, with cure, it cannot occur again in the future. Remission is a different term, which is based upon the current disease status, so what is occurring right now at this point in time and not really in the future. Can you still be in remission and yet still taking medications? And the answer is yes. The current definitions that we used are based upon the disease activity and not what's going on as far as the medication status. So how do we in fact tell that remission is present? And we look at multiple different pieces of information. We ask the person, how are they doing? What are their symptoms? We look at their examination as far as in the doctor's office or the hospital. We look at lab results, and then we can look at imaging tests. And it's really by putting all of these together that we can determine, is there evidence to support that that individual is in remission? And the other thing this really reminds us and tells us is that remission is not currently defined by any one single indicator. So we need to consider each of these 4 areas, which is important in the assessment of every person with vasculitis. But what we need to focus on in each area may differ depending on the type of vasculitis the person has. So what do I mean by that? Let's look at 2 examples that are specific for different diseases. So we'll start with giant cell arteritis. This is a form of large vessel vasculitis in which people often have symptoms related to their head, their vision, the large vessels, or polymyalgia rheumatica, which is an aching along the shoulder or hips. So symptoms that may be relevant to this individual would be asking about headaches, vision changes, pain in the jaw with chewing, if they have pain in their arms with use, or aching in the shoulder or hips. On examination, we're going to pay attention to their arteries along their temples, their eye exam, looking at pulses and blood pressures in the arms and legs, and what are going on with the joints. In terms of labs, we look for features that can go along with inflammation, such as blood counts, sedimentation rate, and C-reactive protein. And imaging tests can also be important in terms of we may do ultrasounds or arteriograms by CAT scan or magnetic resonance. Now we contrast that as far as with what are the features we're looking at in someone that has granulomatosis with polyangiitis. This is a small vessel vasculitis, and again, we can see frequently features of the sinus, the lung, the kidney, and many other organs. So here we may be asking the person about, are you having problems with nosebleeds, shortness of breath, coughing up of blood, eye redness, or numbness or weakness? On examination, we're looking at the nose membranes, examining the lungs, the eyes, their nerve function, and their skin. We once again look for features of inflammation, but here we want to look carefully at kidney function and the urinalysis, as I showed previously. And the imaging here may focus on areas as far as looking at lungs and sinuses. So again, we can see as far as that the concept for remission can be complex. This includes to providers as far as in recognizing that our current indicators are helpful, they are important, but unfortunately they're not perfect. They don't always tell us the whole story. And this is why research is so important in trying to understand better indicators or markers of disease activity and vasculitis. We also understand that the concept of remission is complex at the level of the person. And one of the things that I'll often hear as far as is people will tell me, I'm so glad to hear that you're telling me that you think I'm medically in remission, but why is it that I just don't feel the same as I did before I became ill? And for some people, unfortunately, there may not be a complete correlation between the concept of remission medically and how well it is that they feel. And this can be really for a variety of reasons, some of which you just heard about as far as in the last discussion. The roles of fatigue, medication side effects, poor sleep, reduced exercise and ability to be physically active, our life stresses, if there are other health issues that we had before or after the diagnosis, and also damage that's resulted from vasculitis. And the good news is that many of these can change and be modified. Now, I do want to talk a little bit more about the concept of damage from vasculitis. And we can start with a very simple illustration as far as what is damage by thinking about a sheet of paper. If we crumple that paper up and damage it, it's still a sheet of paper, and we try and flatten it out. It's there, it's the same shape, but it's really not the same as it used to be, and we can't really use it the same way. And damage in vasculitis is similar in the idea that any organ or tissue doesn't go back to the same structure or level of function like it did before. So again, let's consider some examples of what occurs as far as with damage in vasculitis. So sinus damage, this can occur in illnesses like granulomatosis with polyangiitis or eosinophilic granulomatosis with polyangiitis, where people may have persistent drainage. They may have crusted material in their nose or a sense of congestion. And we can see ongoing thickening of the lining on a CAT scan of the sinus. So if we look at this star is highlighting a healthy sinus that is filled with air. And we can see on the other side this thickening of the sinus lining, and this can persist even with very effective treatment. What about nerve damage? So in giant cell arteritis, we can see blindness occur as a result of damage to the eye nerve, the optic nerve. In other forms of vasculitis, nerve damage can affect the arm or the leg nerves, and people may have a persistent sense of numbness, weakness, tingling, or pain from burning as far as that's related to nerve damage. What about the kidney? And again, this can be affected by a number of different forms of vasculitis, and people can be left with poor kidney function or persistent levels of protein in the urine. And we can understand why this occurs when we look again under the microscope at the microscopic functioning parts of the kidney, which is called the glomerulus. And on the left, we can see a healthy glomerulus, and on the right, we can see one that's been scarred and damaged. And it's not difficult to see as far as that looks very different. And so those microscopic structures can no longer function the way they used to, and that results in damage in the kidney. And then the last example, as far as large blood vessels, which can be affected in Takayasu arteritis or giant cell arteritis. We can see on the left a blockage of the arm blood vessel, so that arm is not able to get the blood flow that it used to. And on the right, as far as widening of the aorta, as we can see here, and that's the result of damage. So what are some common questions that arise about damage? Does this always occur? And the answer is no. It's individual to the type of vasculitis, the organ site, and each specific person. Can damage be reversed? Damage can improve, but usually will not go away completely. But in some instances, there are ways to be able to modify damage. So examples could be as far as the use of nasal rinses, which can help to reduce sinus symptoms. Some approaches we have to reduce the symptoms of nerve damage, and physical therapy plays a very important role in that. There are medications we can use to reduce the level of protein in the urine, and procedures that can address narrowing of large arteries causing symptoms, and these are just some examples. What is the relevance of damage to remission, and why am I even raising this? And the reason is because providers need to be able to differentiate damage from active disease in order to be able to accurately determine if someone is indeed in remission. Why do we need to determine this? Well, we want to establish that there is no ongoing organ or tissue injury, because if there is, we may need to take a different approach. And the extension of that is we need to assure that there is no evidence of relapse. And relapse really refers to a return of that active disease after a remission has occurred. Some common questions often arise about relapse, and will I individually have a relapse? And unfortunately, there is no current way of being able to predict if an individual person is going to experience a relapse. Almost all forms of vasculitis carry the potential to relapse, but the likelihood varies for each type. And while none of us like to think about the possibility of relapse, awareness of this potential is important because that allows us to develop strategies to be able to monitor for it and be able to detect it at an early possible point. What triggers a relapse? And this is something we would all love to be able to know. At this point, it's unknown. There are no currently known triggers, but this is a very active area of research. And if a relapse occurs, will it be the exact same as when I was first diagnosed? And this may be, or it may not be. Some people will have very similar symptoms to what they experienced when they were first diagnosed, but we need to keep in mind that something new is always possible. And this is why communicating with your provider about anything you're concerned about is so important. So you are having something new or worse. Does that mean that you're having a relapse? And not necessarily. And the challenge we face is that sometimes other things that look a lot like vasculitis may not be. That can include the damage we just talked about. It can include infections, which we've heard an awful lot about over recent years, medication side effects, or it could be something entirely different that can just look like vasculitis. So remission is the goal, and it can be achieved in most instances. So how do you get there? And almost all forms of vasculitis do require some form of treatment in order for remission to occur. And when we think about treatment as far as active disease going into remission, this is the phase of treatment that we refer to as induction. Once I'm in remission, how do I stay there? And this period after remission has occurred and is maintained is referred to as the maintenance stage of treatment. And the medication options that we use for induction and maintenance will vary by the type of vasculitis, and you're going to be hearing a lot more details as far as specific for each form of vasculitis during this symposium. How long does maintenance medication need to be continued? And this is unclear, but it is guided by published studies and also by person-specific factors. The things we have to consider when we're deciding about maintenance duration includes understanding that relapses pose risk for organ damage and also require increased treatment, which carries its own risks. Staying on maintenance treatment does not absolutely prevent relapse, but there's good evidence to support that the likelihood of relapse is often higher off of medication than on. But this needs to be balanced, of course, against the concern for medication side effects. So how do we decide and factor in? The things we'll often look at is what type of vasculitis does the person have that we've learned as far as from studies that tell us about the risk of relapse. What is the medication that's being used and that person's side effect history with that medication? If organ damage has already occurred, if that person has experienced past relapse, and of course, many other individual factors. Is there anything that you can do personally to prevent a relapse? And again, unfortunately, there is not an exact no to that. You cannot prevent a relapse. And again, I think a very important corollary to stress is if you do have a relapse, there's nothing that you did in order to cause this. However, there are very proactive things that you can do to minimize relapse consequences. And these are some of the things that you heard about in the last discussion. Do take steps to support your health beyond vasculitis, and don't overlook the things that are important to all of us as people, as far as knowing about our cholesterol, doing our colon screening, and for women, things like mammography. Trying to do exercise, even if it's a little, a healthy diet, avoidance of tobacco, and yes, even using sunscreen. You do want to see your provider regularly and pursue a regular monitoring plan with your provider as far as how you're going to be watching for your vasculitis and medication side effects, and let your provider know about any new symptoms. So in concluding, remission is achievable. And really what we've talked about today is that remission is medically defined, but it can be challenging to determine. And it's based upon symptoms, exam, lab, and imaging that's individual for each disease. And again, this is why when you go to your doctor's visits, questions are asked, you have labs, you have imaging, is to try and help determine this. And we understand that this does not always mean that you as a person feel to in the level of returning to how you felt before this illness happened. Relapse can occur in most forms of vasculitis without any known trigger, and we do have to think about carefully as far as differentiating this from damage or other causes and have an awareness of the need for monitoring for relapse. Treatment does play a key role in both achieving and maintaining remission, and the medication choice and duration are based upon the type of vasculitis and individual factors. And I think central, again, to all of these concepts is the teamwork and communication with your provider is essential in understanding what remission means to your provider, what it means to you, how you can achieve it, how you can watch for relapse, and how you can achieve your best health. So with that, I'm thankful again to be here, and I'm happy to answer any questions. Thank you.
Thank you, Dr. Langford. Another wonderful talk. I'll get some of these questions here. All right. So one of the questions that came in, how do I know the difference of a relapse versus something else going on? I know that's, you touched on the importance, but when people are worried about relapses, they're wondering, how do I not be paranoid about every single symptom I have, and how can I try to figure out if it's vasculitis or something else?
Yeah, it can be very difficult to figure out, both for the individual and also for the provider. And yes, I think none of us want to be panicked about every little thing, but at the same time, we do want to know about these things as far as if they are occurring. So again, I think it's helpful to have a discussion with your provider as far as for your individual form of vasculitis. Are there things in particular that you should be alerted to as far as being able to report immediately? There are some common things for almost all forms as far as things like fevers that we would want to know about right away. So it can be very difficult to be able to tell these things apart. But again, I think communication about understanding what are the things in particular for you to be able to watch out for, and having a low threshold to raise that awareness with your provider is important.
Thanks. How would a vasculitis patient, know what symptoms should be reported to their rheumatologist versus their other doctors, like a PCP or other specialists?
So, I always want to know as far as about symptoms because, again, I'm usually the one that's providing the medication and prescribing those. So I want to be able to know as far as if if someone is having concerns that could influence as far as with their treatment plan. So in general, it should be as far as the provider that really is providing the majority of your care and prescribing your medications. And again, that would be a discussion to have with that person up front as far as what should I do in this instance, and should I be reporting these as far as to you or to one of my other doctors. But in general, it's going to be to the person that's prescribing the treatment for your vasculitis.
There's a couple of disease-specific questions, and I want people to know that you can ask those questions. There will be specific disease breakout groups. So I'm not going to, just for the broader audience, I'm not going to ask some of those specific ones. But more broadly, can you be in remission if some of your, I know you said there's a puzzle right up there, but if some of your titers are persistently positive, for example, an MPO or a PR3 or any other lab tests that are still abnormal despite years of medication, person's feeling, well, are you in remission or are you not in remission?
Yeah, so I'm going to actually use the example of a little bit broader test that's commonly used, probably most forms of vasculitis, which is something like a sedimentation rate or a C-reactive protein. So yes, you could be in remission as far as, again, each of these is a piece of the puzzle. And almost all of them have their potential limitations as far as that they could go along with active vasculitis, but they could go along with something else. So in the case of sedimentation rate and C-reactive protein, one of the most common scenarios is they actually go up in infection. Also, for some people, they may be persistently elevated, and that doesn't mean that there's active disease present. So these are clues that we do need to pay attention to and that we do need to investigate. But yes, it can still be possible as far as if one of the lab markers, or if there is a symptom present, or if there is an imaging finding within the context of what we're looking at in total.
Thanks. And then with vasculitis, you talked a lot about how the blood vessels are inflamed, and we know vigorous exercise or exercise can put stress on some of the blood vessels. So what do you think is a good balance between rest versus exercise and trying to maintain that balance?
Yeah. So again, this is something that you would want to talk with your doctor about individually, as far as what type of physical activity and exercise can I do and that would be healthy for me. So there's going to be a lot of variation in that, as far as someone who maybe has been very recently ill, or they may be on high doses of prednisone, where it can be difficult as far as to do certain types of exercise and muscle building. Or there may be other issues that can impact that, as far as if someone has high blood pressure, or they have other issues, heart-related issues, that will factor in with exercise. So having a discussion about what an appropriate exercise program for me would be is also an important point of discussion.
Great. And we'll wrap up with this one. What is the difference between relapse and refractory vasculitis? Does it mean the same thing?
No. So, again, these are medical terms that we will try and use, as far as particularly, again, for those of us who are trying to investigate different therapies. Relapse generally means as far as a point in time where someone has gone into remission and now they have had a return of disease-related vasculitis or inflammation. Refractory disease generally means someone who maybe they've improved or maybe not, but they've never achieved remission and they continue to have active disease that's causing ongoing organ injury that requires a different treatment approach. So yes, they are different.
Thank you. Should we move on to break, I guess? Okay, thank you so much, Dr. Langford.
Thank you.